Hello, my name is Amalia Stefanou. I'm a colorectal surgeon at Henry Ford Hospital in Detroit, Michigan, and I'm going to be talking about PSI 90 and effects of minimally invasive surgery on outcomes. Okay, we have no disclosures. So patient safety indicators are really important outcome measures that our hospital administrators know a lot about, and I don't think surgeons know enough about. They have evolved in their purpose over time, and they have been developed by the Agency for Healthcare Research and Quality, and they were initially developed to identify preventable harm events and be provided to institutions for local quality improvement. And they really focus on in-hospital complications after surgery, procedures, and childbirth. But they've evolved, and they now are used for reimbursement, quality reporting, and hospital rankings. This is a list of the current patient safety indicators, and there's provider-level indicators, which is the larger group on the screen, and then area-level. And we're going to focus more on the provider-level indicators, but you can see they're really broad. So it could be death in the hospital or post-op issues like PE, sepsis, and then there's the obstetric ones there, as well as pressure ulcers is on the list as well. So PSI 90 is a composite score of several of the patient safety indicators that the AHRQ think are the most important. And they have varying weights in this PSI 90 score, and they're based on smooth hospital morbidity ratios. There's specific inclusion and exclusion criteria that are used, and they provide an overview of hospital-level quality data as it relates to preventable harm. And this is where it's really important to reimbursement, and there can be penalties that hospitals face when they don't reach appropriate metrics. This is the current PSI 90 component. So the right side of the screen are the indicator numbers, and then the indicators in the middle, and then the component weights on the left. And you can see they range from in-hospital fall with fracture, down to sepsis, wound dehiscence, et cetera. These are the three that are the most important because they're the largest contributors. So post-op respiratory failure, post-op PE DVT, and post-op sepsis. So PSIs are important, but they're not always well described in the literature. So there's a lot of different literature that says they are good representations of outcomes. There's others that say they don't accurately represent clinical care. There's other papers that talk about, well, what modifies PSI? Could it be patient demographics, kinds of cases that you do? Even teaching hospitals versus private hospitals. So we hypothesized that using our hospital system database that MIS surgery would be associated with fewer PSI occurrences leading to fewer adverse surgical events. And this kind of goes along with what it's already described about minimally invasive surgery versus open. We used our large 5-hospital health system in Metro Detroit. Our main hospital, which is pictured here, is over 900 beds, provides high-level quaternary care, and also is a safety net for the local population. And then we have 4 community hospitals in the suburbs. There's significant diversity in our health system in terms of patient demographics and clinical complexity. Most of the very complex care is done at our main hospital. And then we chose colorectal surgery as our operations of interest because it's performed at all 5 of our hospitals, but there are varying groups of surgeons at each of the hospitals, and our project was IRB exempt. We queried our data set by ICD-10 codes for minimally invasive versus open colorectal surgery. Minimally invasive is kind of a proxy for laparoscopy because robotic cases are coded a bit differently. We looked from January 2018 through the end of 2019, compared clinical and demographic variables, and our outcomes of interest were the PSI events from PSI 90, and we used the 2020 AHRQ definitions for that. These are our results, kind of a selected group of the results. So there were about 1,380 cases overall, more open than minimally invasive. There was no difference in the 2 groups by race. By hospital type, there was more MIS surgery done at the academic center at the main hospital, but more operations overall done in the community hospitals. Medicare and Medicaid patients more likely had open surgery. Urgent and transfer patients were more likely to have had open surgery, and then elective and diagnosis of neoplasm were more likely to be done MIS. There were similar Charlson comorbidity scores between the 2 groups, but there were slightly higher patients with CHF and renal disease. and the MSDRG weight was slightly higher for open surgery. Our outcomes show that there were higher mortality, inpatient length of stay, inpatient ICU length of stay, and then readmission at 7, 30, and 90 days for patients who had open surgery. This is the univariate analysis for PSI 90, and I want to just point out the denominators are different for all of the different groups because the PSIs have very specific criteria to include or exclude them from the outcomes. But the only statistically significant difference was for PSI 12, which is periop PE or DVT. Post-op respiratory failure showed a trend with more in the open group, but not statistically significant. This is the multivariate regression comparing MIS versus open by PSI, and there was no significant difference between any of the groups. So in conclusion, we looked at our MIS versus open colorectal surgery, and we disproved our hypothesis. We found that there were similar rates between race and sex for MIS versus open surgery. Medicare patients were more likely to have open surgery, similar comorbidity scores between the two, and patients having open surgery did have more urgent operations, longer length of stay, and higher rates of readmission. But the only difference on univariate analysis was in PSI 12, and on multivariate, no difference. So thank you.